morning, and I am honored to be here and really delighted to be here on a morning where I did not have to rewrite my slides because I can still be talking about provisions of the Affordable Care Act. Trust for America's Health is what I like to call an evidence-based advocacy organization. So we're a non-governmental organization. We focus on policy and systems change. We don't run anti-obesity programs, but a major portion of our work is obviously focused on obesity issues. But we're trying to change policy and systems primarily at the federal level. And what I'm going to talk about today is, there we go, it moves faster there than here, is really three trends in what is happening in the United States as I talk about the argument and the case that we make around a return on investment. The first is that we're seeing the first panel talked about culture change, and one of the cultures that has to change is within government. And in the United States, at least, we're seeing much more of a health in all policies approach, and that's been driven to some degree by the Affordable Care Act, a recognition that it's not just what the health agencies do, but it's also what housing does, what transportation does, what economic development does, that makes a difference in terms of health outcomes. And clearly, the Affordable Care Act makes some major investments in community prevention and community-based programs similar to a PUD, but also says to the healthcare system, you need to thinking about the community and not just what happens in your clinical system. So it's all about making the healthy choices the easy choices. And a lot of this change, and this is where we get to the return on investment, a lot of these changes are driven by the reality that we can't solve the biggest cost drivers in the United States healthcare system through clinical interventions alone. That in fact, what happens in the community makes a huge difference in terms of health outcomes and also in cost outcomes. Now, this is a quote, since we're from Senator Tom Harkin, who is probably he was the chair of the Health Committee in the United States Senate and was the biggest advocate for introducing community prevention into the United States healthcare system and to our public health programs. He was behind the Prevention and Public Health Fund, which is providing $12.5 billion over the next 10 years in guaranteed funding for public health and prevention programs, including some of the very specific community-based programs. But I think I have this quote here because I think it's an example of the culture shift that is happening among some policymakers in the United States in understanding, and what he says here is that we all appreciate that checkups and immunizations and other clinical services are important. But where Americans live and work and go to school also has a profound impact on our health. And that's the philosophical shift that we've begun to see in the United States. During the debate around the Affordable Care Act, my organization, in order to, in a sense, provide the rationale for these kinds of investments, my organization partnered with economists at the Urban Institute, which is a major think tank in the United States, the New York Academy of Medicine, which brings a lot of public health expertise, and the Prevention Institute, which is another advocacy organization based in California, to produce this report called Prevention for a Healthier America. And what the Urban Institute folks did was develop a model that showed if we introduced evidence-based programs into our system, focusing on non-clinical interventions, what would be the impact on diabetes, on heart disease, on certain cancers? And with a one-time change, but a consistent investment over time, what we found was that for every dollar invested, we'd see $5.60 in return just in healthcare costs. This wasn't looking at productivity, it wasn't looking at quality of life, just in healthcare costs. Because remember, the context of this report was the debate around the Affordable Care Act, and so everyone was focused on healthcare costs. What was interesting, and so I wish I could say we modeled a 10% reduction in obesity. I can't, and why? Because even though the evidence showed that we could achieve with some of these programs 10% reduction in these diseases, whenever we talked to people about that and that the evidence showed it, they didn't believe us. And so we actually modeled the savings on a much lower return on investment So a 5% reduction in diabetes and heart disease and stroke, and a 2.5% reduction in cancer, because we had to bring this evidence into a debate where people just couldn't believe that that relatively small investments and relatively small changes could actually make that big a difference. So it's an interesting context to how we present some of this data. Sometimes people just don't believe how successful community programs can actually be. So one of the new programs created in the Affordable Care Act and now underway is something called Community Transformation Grants. Now, this truly is modeled after APUD. As we worked with congressional staff in designing this program, we really pulled from that evidence because it is some of the strongest evidence. It's got an American twist to it, but the principle is essentially the same, which is focusing on policy, environmental, and cultural changes in communities, very community-oriented, while money goes, this is federal money, $900 million, not $900, $900 million over 5 years. It's a major investment, requiring communities to create coalitions, build coalitions that bring together health, business, education, other community representatives, and whoever else may be relevant to the issues they are dealing with. Sometimes that may mean public safety because we need to worry about whether it's safe for people to play outside. Other times it might be the Parks and Recreation Department so that we can improve access to parks and build playgrounds, that sort of thing. And also a requirement that local elected officials be part of that, because that we also did borrow very strongly from the APOD model, which is if the local political leadership isn't with you, you're not going to achieve that kind of change. Now, every community is required to adopt evidence-based practices, but there is no requirement of specific practices because, as Jacob said earlier, there isn't a single answer. Something policymakers always want to hear, oh, but if we just did one of these things, what would make the difference? And that's not the answer. You have to do all of these together. The only restriction, and this was imposed by Congress, is that these communities cannot be developing policy and supporting implementation of any new taxes. So that was related to sugar-sweetened beverages. But this is a major change in how the United States is doing this work. So again, we had to make the political case and also the economic case for this program. And so we specifically focused on the targets of the community transformation grants. So they're expected to address not just physical activity and nutrition, but also tobacco and access to certain clinical interventions. But on the obesity front, the performance measure is a 5% reduction in average BMI. So that's not 5% reduction in obesity or even 10%. It's a very modest goal, 5% reduction in average BMI. And we worked with folks at the National Heart Forum to use their model to estimate what the kinds of savings would be over time. And what we found was so here you will see I can get these colors right. The green line is if we continue over current trends. So that's the projection what healthcare costs would be over time. The blue line is if we achieved a 1% reduction in average BMI, and then the red line is what healthcare costs would look like with a 5% reduction in average BMI. And so the grantees here are expected to achieve this within 5 years. And so looking 5 years forward in 2017, over the 5 years from 2017 to 2022, we would see a savings of $158 billion if every part of the country were engaged in this kind of activity. Oops. We've also been working very hard to make the business case for this, because certainly in the US context and certainly in the current economic climate, we need to be showing that this is not just about health, but it's also about rebuilding the economy. And so we've worked with the business community to try to identify how their engagement, not just in workplace wellness, but their engagement in their communities results in a more productive workforce. And finally, part of the Affordable Care Act was a requirement that there be a national prevention strategy developed by the National Prevention Council that was created, which is 17 agencies across the federal government. And here you see the overall objective, which is increasing the number of Americans who are healthy at every stage of life, which everyone can certainly agree on. But then the 4 strategic directions, I think, are particularly important for the conversation we're having today. Because while it talks about clinical and community preventive services, it also talks about healthy and safe community environments, which means not just clean air and safe drinking water, but it also means walkable communities. It means having active living options. It means making sure that schools are promoting physical activity. And it also means that people have safe and affordable housing, because we know that safe and affordable housing has a huge impact on health outcomes. And when talking about elimination of health disparities, it's not just the quality of care you get in a clinical setting, but also that we start addressing some of the social and economic factors that influence obesity and other health outcomes. And finally, this concept of empowered people, which is actually relatively new for the United States conversation, which is really about having people engaged in the decisions that affect their lives and participating in things like the community coalitions that are forming around the community transformation grants, so that their needs are responded to, and just by being activated, we improve health outcomes. So that's a little bit of the United States context, and I think provides a sense, I hope, of how important, at least in bringing this cultural shift to how the United States addresses prevention, has been driven to a large degree by the return on investment argument. Thank you.